Good afternoon, everybody. I'm Dr. Deepti. I'm an obstetrician gynecologist. I live in Goa. And today I'm going to talk about something very close to my heart, the gender health gap in India. How do we bridge it? It was 2013. I was a young resident in OBGYN. I'd seen many surgeries, but this one was different. As I looked into the belly of that 23-year-old girl, there was pus everywhere. Her intestines were matted together. This was a girl that had gotten pregnant outside of marriage, but she was too scared to go to a hospital in case her parents found out. So she scraped together all of her savings and she went to an untrained practitioner. She developed an infection so bad, we had to take out her uterus just to save her life. Today, 8 women in India will die due to unsafe abortions. 67% of abortions carried out in India today are unsafe. Now, these are staggering statistics if you consider the fact that India has one of the most liberal abortion laws in the country. Somewhere across the country, we have 47-year-old Preeti. She's been having some vague lower back pain, some neck pain, and on that day she felt particularly low. So she drags herself to hospital. The doctor there asks her pointed questions about her husband, her family, her work, when her last period was, tells her it's all in her head and sends her home. Hours later, Preeti's pain becomes excruciating. She goes back to the hospital and someone finally takes an ECG. Preeti was having a heart attack. Studies show that when women go to the hospital with symptoms that could be heart related, they are twice as likely to be diagnosed with a mental illness rather than a heart condition. There are two kinds of bias. Explicit bias is bias that we're aware of. But implicit bias is bias that is so deeply ingrained in us that we hardly know it exists. Bias that is there through ideas that have been fed to us since our childhood, and they affect our actions, our interactions, and our decision-making process. Implicit gender bias affects the way that women and members of the LGBTQ community can access healthcare in two very distinct ways. The first way is bias that is present within our community and within our households that makes it hard for these groups of people to reach a doctor on time. The second type of bias exists within our healthcare system, and it changes the way that healthcare professionals view these groups of people and the symptoms that they have. To understand where this bias comes from, let me take you to a walk in the history of medicine. It's the Middle Ages. Medicine is dominated by men. The great minds of the time are Aristotle and Galen. Women are perceived as lesser versions of men, to be kept at home, to be discouraged from pursuing knowledge. Women were considered fragile, labile. We are governed by our emotions. The way that male and female anatomy was viewed greatly differed. A 15th century medical text describes semen as a pure substance separate from any other kind of body fluid drawn straight from the brain. But the uterus was given far less credit. Even though the uterus could bear life, it was considered cold, dry, a sewer for noxious poisons. Anything and everything could be blamed on the uterus. In fact, the Greek thought that the uterus was a wandering villain, that it could move around women's bodies, and if it went to the brain, it put pressure on the brain and gave you a headache. If it went to your chest, it gave you chest pain. If it went to your throat, it choked you. What was the cure for all of these ailments? Marriage, sex, pregnancy, childbirth. As medicine advanced and anatomy grew clearer, they no longer thought that the uterus was a wandering nomad, but it was no less of a villain. Since the second millennium BC, right up till the 1970s, all of the symptoms of women could be clubbed under one diagnosis: hysteria. From the Greek word hysteris or uterus. It was no wonder then that hardly any men were diagnosed with hysteria, but it was exclusively for women. It wasn't until 1980 that hysteria was removed from medicine as an official diagnosis. Now you might think times have changed since then, right? But a 2018 study that looked at the way healthcare workers viewed different genders with chronic pain symptoms had some interesting findings. When the healthcare workers were talking about men, they used words like stoic, brave. When they were talking about women with the exact same symptoms, they used words like emotional, complaining, time-consuming. There is this big gender gap in medicine. And one of the reasons why it exists is because for the longest time, biomedical research studies only involved men. Till today, transgender individuals are excluded from vaccine trials because they come under the vulnerable population. But women were excluded because research was afraid that they'd get pregnant and drop out and mess with their results. They also were not very happy that we have a menstrual cycle and our hormones go up and down, and this may bias results. But this kind of thinking is inherently flawed. The genders differ because we have different biochemical hormones that are coursing through our veins. And this means that what is normal for a man may not be normal for a woman or somebody from another gender. Symptoms for the same disease may differ markedly. Drugs may be metabolized differently. The same treatment may have different outcomes. Let me give you an example. When a woman has a massive heart attack, she may not have the crushing chest pain that you may typically see in a man. It may be as subtle as a backache, nausea, indigestion, jaw pain. There might sometimes be very little or no chest pain. But most doctors aren't trained to view symptoms through the context of gender. Is it any wonder then that a woman having a massive heart attack is 40 to 50 times more likely to be misdiagnosed than a man having a heart attack? A recent Forbes article chronicled this incident in the history of a transgender woman who was a doctor and admitted with COVID-19 in the hospital where she was a consultant. Her chest x-ray showed shadows, which were from her breast implants. But the doctors thought it was pneumonia and they gave her a course of unnecessary antibiotics. I mean, nobody thought to ask her about her medical and her surgical history pertaining to her transition. This gap in the way we look at symptoms through the lens of gender has been conspicuously missing in our education. A 2008 study looked at 11 medical textbooks, and they found that gender-specific symptomatology and information was mostly absent. In fact, when I was an MBBS student, some of our textbooks had frankly transphobic stuff in them. For example, our forensic medicine textbook listed lesbianism as a sexual perversion, a statement that was retracted only in 2021. On the far end of the spectrum, consider contraception, pregnancy, childbirth, all the exclusive primary responsibility of women. However, the enjoyment of sex seems to be the domain of man. In the late 1950s, we finally invented birth control, something that revolutionized things for women. We could finally plan our pregnancies. But it's been 80 years since then, and we still don't have the equivalent of birth control for men. Why is that? It's because most of these pills are hormonal, and they have side effects, right? There's a drop in libido, there's weight gain, there's nausea, there's bloating, acne, mood swings. Most of these symptoms are quite familiar to us women, but are deemed unacceptable in men. As a result, male contraception has two options: condom, vasectomy. Now, vasectomy is a relatively simple procedure. It's quite superficially done, so we only need local anesthesia. There are not many side effects. It's easily reversible. It does not affect the libido of a man. If you contrast it to female sterilization, we need deep anesthesia. We need to cut through layers of the abdomen of the woman, reach deep into her pelvis, pick up her tubes, cut them. There are side effects, there are long-term effects, and it's a nightmare to reverse this surgery. Yet, of all the people sterilized in India, 95% are women. 1 in 2 women in India above the age of 36 have been sterilized. If you compare this to men, less than 1% of all of the men in India have had a vasectomy. Now that 23-year-old girl lying there on that OT table that night, she had options. She had rights. Why wasn't she able to exercise them? And what can we do to change things? Education is key. Unless we know our rights, how can we exercise them? And we have made progress. The Indian government has put in a lot of programs where women and other minorities have been uplifted, especially in rural areas. In 2020, a law was passed in India that transgender individuals should have mandatory access to healthcare. In some countries of the world, it is now illegal to exclude women and other minorities from research studies. But we have a long way to go, and we may have a missing link here. Think about the typical Indian household. Who is the primary decision maker? It's the man, usually. Now, it's easy to assume that men have little to no interest in women's healthcare, and the roots of patriarchy are so deep that we cannot pull them out. But what if that's not true? A study showed that although most healthcare awareness programs were aimed at women, when we educated men, that's when change started to happen. Men started to open up their minds about the various problems that the women in their family faced. They began to take an interest and to take an active part in decision making, and this really drove change. The study also showed that in households that women had lower literacy levels, the men seemed to take little to no part in these conversations. It's been my experience that women who have the mindset of patriarchy, they tend to shield the men and the boys in their household from the gory pain of period cramps, the horrors of childbirth, and the thankless task of picking a method of contraception. These stones of patriarchy, they know no religious barriers, they know no socio-economic barriers, they know no caste barriers. It's there in all of our lives. So what can we do to change things? Let's start with the little things. Let's all sit down together and have dinner instead of making the men go first. When mom's on her period, let's not cover that packet with newspaper. Let's make her feel better about her cramps. And slowly things will begin to change. We will have more representation in researchers, policymakers, and politicians. We will have a new generation of doctors that are gender sensitive. Our children will have comprehensive sex ed, so they know what their options are, they know what their rights are, and they know where to go to access them. And to each and every person out there of every gender, if you think that there's something the matter with you and your doctor's not taking you seriously, fight for yourself. Write down your symptoms. Go back. Politely insist that they take another look at your chart. Don't ever let a healthcare professional talk down to you or laugh off your symptoms. If you need to, change your doctor. Your greatest and your best advocate will always be you. I want to leave you with this. Angela Davis said, "I am no longer accepting the things I cannot change. I am changing the things that I cannot accept."